Welcome to this lecture. Today I'll be discussing etiology of male and female infertility, investigation of the infertile couple. My name is Dr. Stephen Ambuchuchi, National Registrar, Aetiology, Ile-Ife. At the end of this discussion, we are expected to be familiar with the different etiologies of infertility, to be able to know how to investigate infertile couples, and also to be able to know the possible approach to managing an infertile couple. Infertility has been defined as inability of a couple to achieve conception within 1 year of unprotected regular sexual intercourse. Regular sexual intercourse meaning 3 or more times of sexual intercourse in a week. There are terms that have been used to describe the fertility of a couple. One of them include the fecundability rate, which describes the chance of conception per month attempted. This has been said to be 20 to 25% in normally fertile couples. Fecundity rate is also another term which describes the probability of achieving a live birth in one menstrual cycle a woman is exposed to unprotected sexual intercourse. Infertility is an important issue because it's a public health challenge, especially in climes like ours where procreation is accorded great cultural and social value. So it constitutes a major and significant bulk of distress, and also to a gynecologist in this region, which about 65% of gynecological consultations is mainly on infertility issues. About 85 to 90% of couples will achieve conception in the first 12 months, and about half of this remaining 15% will achieve also conception in the next following 12 months, giving about 92% within 24 months. 1 to 2% of couples have been quoted to be sterile. Sterility implies the innate inability to achieve conception. Overall, that is globally, 15 to 20% of couples will present with infertility. However, in some parts of West Africa, it ranges up to 20 to 46%. But in Nigeria, about 20% on average have difficulty with conception. According to different etiologies, 30 to 40% of causes of infertility have been attributed to male factors, and about the same rate is also attributed to female factors. 10 to 20% has been attributed to combined factors between the male and the female, and 5 to 10% has been said to be unexplained. The NICE guideline have brought out some possible etiologies of infertility. In 2013, it was attributed to 30% was attributed to sperm abnormalities, which may include oligospermia, azoospermia, astenospermia, and other abnormalities of sperm tests. Also, about 25% has been attributed to ovulation problems, which may include absence of ovulation entirely, or poor egg quality, or premature ovarian failure. 20% has been attributed to tubal problems, 10% to uterine problems, 10% to combined factors in male and female, and about 5%, as I mentioned earlier, 5 to 10% has been attributed to unexplained etiology. Infertility in Nigeria is mainly due to secondary causes, mainly secondary infertility, usually following a tubal and upper genital tract pathology, which may arise from sexually transmitted infections, post-abortal sepsis, or post-puerperal sepsis. Infertility in women, as it regards to age, has been comparing between men and women. Age has more effect on the fertility of women, as can be seen that in women that are less than 30 years, they have about 10% rate of infertility. However, from 40 years and above, about 60% of women have infertility. At puberty, there are about 300,000 primordial follicles in the ovary, in each of the ovary of a woman. There is each month, there is dominant follicle that produces estradiol, which leads to luteinizing hormone surge, and ovulation occurring about 24 to 36 hours following the luteinizing hormone surge. And the receptivity of the endometrium in this cycle can be, in a 28-day cycle, can be between day 16 to 19. It is worthy to note at this point that the single most important determinant of a couple's fertility is the age of the partner. At the age of up to 25 years, it is said that conception rate is up to 60% in women. At 6 months, they can have up to 85%, but from age of 35 years or more, the rate of conception in 1 year drops to 60% and 85% at 2 years. The other factors influencing the likelihood of a spontaneous pregnancy also is in shorter duration of infertility. In couples that have shorter duration of infertility, the chances of achieving a spontaneous pregnancy is higher compared to those who have longer duration of infertility. And also in people that have had a previous pregnancy, it is more likely that the couple can conceive compared to those who have not had a previous pregnancy. Also, the effect of age of the male partner on infertility, however, is less clear. But it is also noticed that as the age of the male partner increases, there is reduction in infertility. There are some principles that we need to note that management of infertility can be very challenging in developing countries compared to developed countries. And the reasons are obvious because of our paucity of investigative tools and lack of a well-designed protocol in most centers. Usually the inability of many couples to afford the investigations, as couples have to pay for these investigations from their pockets, unlike where in other climes where there may be the health insurance that can subsidize the cost for this. So this contributes to the challenge in managing infertile couples in our environment. So we are going to be noting some best principles or practice points that will help to reduce this challenge. And one of them include that there should be a simple and systematic protocol. For managing every infertile couple, the approach should be very simple and systematic and not haphazard. And any investigation that should be requested for should be evidence-based and should be targeted at achieving conception. And each investigation should be stepwise in the manner of planning and execution of those investigations. It should be stepwise, and it should be aimed to reduce time and cost. Investigations should be individualized to the peculiar history and clinical findings in the couple. There should not be a blanket armamentarium of investigation for every couple. It should be individualized for each couple. And then there should be proper counseling on first visit of the couples, that they should be made to understand that they have to follow the stepwise investigations and they have to comply, that in management or treatment is going to be started when investigations has been completed. So this information should be passed to them right from the first consultation so that it will enable them to understand what they are entering into and be able to cooperate with the clinician. Then also, couples should also be offered psychological support, as we have mentioned earlier, that infertility constitutes a lot of stress, psychological stress to the couples that are involved. So they should be managed with understanding. They should be offered psychological support during the investigation, after the investigation, even before the investigations are started. The classical history it should be approached from history taking, examination findings, and then investigation. And also, in all this process, privacy and sufficient clinical time should be offered to the couples. In each stage of the investigation and treatment of infertile couple, they should be fully carried along. They should understand what is being done at each level, at each stage, and if possible, written information in a range of language should be offered to them if feasible, so that they can understand clearly what is being done. The approach to a patient or to couples with infertility, one of the issues that should be considered is when to begin investigation. The time to begin investigation is generally agreed after 1 year. That is from the definition of infertility, which has been defined as inability of a couple to achieve conception after 1 year. So usually investigation of a couple with infertility starts after 1 year. However, this can be started earlier, especially if the age of the woman is greater than 35 years, as we mentioned earlier, that from 35 years and above, if the chances of conception in a woman reduces drastically. And it's also if there is a previous history of pelvic inflammatory disease in either of the couples, which are risk factors for infertility, this can be an indication to start investigation earlier than 1 year. If there's also history of post-abortal or puerperal sepsis, which could predispose to tuber pathology, there was previous history of sexually transmitted infection in the man, or history of surgery for undescended testes in the man. This could be indications to start investigating an infertile couple earlier than the usual 1 year. Also, the clinician should try as much as possible to enlist the confidence of the couple and ensure compliance to the management protocol. In all the clinician is doing, he should be sensitive to the couple, and the management should be couple-centered. Like I mentioned earlier, they should be carried along each stage of the investigation. Managing a couple with infertility begins with history. As I mentioned earlier, there should be good and detailed history, and the clinician should be sensitive in asking questions. Some more sensitive questions can be asked when examining individual patients, other than asking the sensitive questions in the presence of the other partner. And the clinician should be able to be ready to proceed with investigating or taking history from the female partner initially before coming to the male partner. The pertinent things that should be sought in the female medical history that may contribute to infertility include the duration of the infertility, which is very important. As we mentioned earlier, that the lesser the number or duration of infertility, the more chances of a spontaneous pregnancy subsequently. So this needs to be established from the beginning, the duration of the infertility and the coital frequency, because we mentioned that the regular or the number of times that should be that the couple should have sexual intercourse in order to increase the chances of having spontaneous pregnancy should be at least 3 or more times in a week. So that should be established, because that may just be the reason of the infertility, and if addressed, the matter will be over. There should also be history of the pubertal development in the female, if there is history of dyspareunia, and also the menstrual history. Very important, because a woman that is not menstruating or that is having an abnormal or irregular menstruation may be a pointer to ovulation factor infertility. History of prior pelvic inflammatory disease should also be sought for, and if the woman has had a successful or previous conception, that should also be sought, as the chances of getting a repeat pregnancy if the woman has had subsequent pregnancies is higher than when it is primary infertility. That should also be sought the history of medical conditions which could be a contributing factor to infertility, such as diabetes mellitus or thyroid disorders, either hyper or hypothyroidism. Then for the male factor, some of the pertinent histories is history of possible congenital abnormalities, either Klinefelter syndrome, which could predispose the man to infertility. There should also be history of, it should also seek for the history of undescended testes if she has fathered any child in the past, and also history of previous surgery, especially groin surgeries, which may have affected the production of sperm or the transport of spermatozoa. If also there are medical conditions like hypertension or diabetes mellitus, which could predispose the man to having a low libido or erectile dysfunctions. So in the examination, the aim of examination is to establish the general health of each partner. So there should be an overall assessment to know the general state and health of each partner, to also establish the etiology further in the examination, to also identify associated complications that may be present. The clinician should also be sensitive to social factors that may also have been, the infertility may have contributed to, such as if in the woman there is already evidences of physical abuse, or there is evidence of neglect or emotional abuse, because this also needed to be addressed, not just the medical etiology or the medical complications of whatever may be the etiology of the infertility. The other thing that also needed to be noted in the examination is also if there are other comorbidities that may also influence or interfere with the fertility of a couple, such as if there is presence of uterine fibroid, there is coexisting hypertension or tuberculosis or any other chronic illnesses. And this should be deliberately sought for. And if there is also any other condition in the woman or in the man that may contraindicate pregnancy, especially in the woman, if the woman is having probably stage 3 or 4 cardiac failure, this needed to be treated or handled prior to conceiving, or there is presence of breast or cervical malignancy. These are things that needed to be addressed before the woman can be encouraged to get pregnant. In the general observation, as the couple or as the woman comes in, should begin with understanding the body language, because when the couple walks in, their body language can betray some of what is happening in the house. Probably there is already separation, there is already emotional or psychological abuse or physical abuse. So the clinician should be observant to notice any body language that may betray this, so that it can be handled, and also to note the general nutritional state of each of the partner, and observe any sign of physical abuse. You also be looking out to observe any telltale signs of probably a sickle cell disease. Maybe there is frontal bossing or depression of the nasal bridge, which may be features of sickle cell disease, or features of systemic lupus erythematosus, probably a presence of butterfly rash on the face, or excessive sweating that may suggest hyperthyroidism, or slurred speech that may also suggest hypothyroidism. So these factors should be looked for as the physician is examining the woman, or there is odor of alcohol consumption. This will be the issues that will be addressed. For the examination of the female, you should also note the weight and the height and the body mass index, which may contribute to irregular menstrual cycles, or which may suggest polycystic ovarian syndrome in this patient. You should also look at the hair to know the texture, if there is already recession, temporal recession, or alopecia that may suggest hyperandrogenic state, or if there is any features of anemia, probably features of acanthosis nigricans, which may also suggest diabetes mellitus. On the neck, you look for thyroid gland enlargement, which may be hypo or hyperthyroidism. On the breast, we assess the terminal stage of the breast to know if there is adequate pubertal development and maturity, which if pubertal development or maturity is not adequate, that may be a pointer to the cause of infertility. The chest, you should examine the chest to make sure there is no chronic chest infection or cardiac disease. On the abdomen, you should observe the pattern of hair distribution. If there is male pattern in a female, that suggests hyperandrogenism, and this may be the cause of the infertility. We also look for scars on the abdomen, probably from previous surgery, that may suggest probably pelvic adhesions that may have caused a distortion of the fallopian tubes leading to the infertility. You should also look for presence of uterine fibroids or ovarian masses. On the vulva, we should inspect the vulva. If there are any telltale signs of hyperandrogenism like clitoridal enlargement, it should be noted. And on sputum examination, one should also examine the cervix to know if there is any endometriotic nodules or ulcers or polyps that may also suggest the etiology of the infertility. The uterus should be examined if it is enlarged or irregular shaped, maybe suggesting or presence of masses suggesting uterine fibroids. And also the adnexia, probably the adnexia tenderness, that may suggest chronic pelvic inflammatory disease or tubal or ovarian pathologies. So in the examination, it should be thorough and detailed, because this could actually give away the cause of or the etiology of this infertility. Similar in the man, there should also be examination of the height and weight, determine the body mass index, and also note if the man has a unicoid build. That is very important, because that may be a contributor to the infertility. Should also examine the breast if there are probably a pseudo or true gynecomastia. It should also be noted. And the abdomen, if there are surgical scars. If the man is having a chronic liver or renal disease, probably there may be hepatomegaly, or the kidneys may be ballotable. These are factors that contribute to infertility. Then also the examination of the genitalia should examine for previous groin surgeries, probably presence of scars, or there is bulges or ulcers in the inguinal region. This, or there is obvious penile or scrotal abnormalities, which may predispose this man to infertility. The penile size should be noted. If there are inappropriate or infertile penile size, obviously the etiology of that should be sorted, which may be what is causing the infertility in this couple. Should also examine the testis to be sure is inside the scrotum and is of average volume of about 15 to 35 ml when measured with the Prado orchidometer. Then the investigations. There are principles that guide the investigations, and these principles is that one, it should be concurrent with both partners. The investigation should run concurrently for both partners. And as I mentioned earlier, it should be couple-centered. They should be carried along. They should be each process that the clinician wants to take, they should understand it fully. This will encourage their participation and their cooperation too. And it should not be haphazard and long drawn out, because so many patients can be lost to follow up if the duration is long drawn out. They are just going through one investigation to another over a long drawn out time. They may get discouraged and get lost in to follow up. So initially, for the man, we start with the seminal fluid analysis and culture on day one, because we need to target to finish this investigation as much as possible within one cycle of the woman's menstrual period. So in one menstrual cycle, the investigations for infertility should be targeted to be done. So on day 1 or day 2 to 3, on day 1, there could be seminal fluid analysis, that's for the man. On day 2 to 3, the woman can have hormonal assay done on that day 2 to 3. And hysterosalpingography can be done on day 6 to 10 of the woman's menstrual cycle, and probably plus or minus laparoscopy and dye test if indicated. Then on the mid-luteal phase, depending on the number of days of the cycle of the woman, if it's a 28-day cycle, on day 21, you can have serum progesterone done. This is just an outline of what I mentioned earlier. On day 2 to 3, you can have seminal hormonal assay for the woman. On day 6 to 10, you can have assessment for tubal function, which can either be hysterosalpingography or laparoscopy and dye test if indicated or if readily available. And also can have a transvaginal scan to assess the uterine cavity. In places where it is also available, you can have hysteroscopy done for the woman to also assess the uterine cavity for possible causes of the infertility. You can have semen analysis for the man and other investigation that could be indicated depending on the peculiar scenario. Could be uterine Doppler to assess the uterine trace. It could be immunological tests or antiphospholipid antibodies if indicated. The investigations that should be done, according to the European Society for Human Reproduction and Embryology workshop that was done in 2000, they classified the different investigations that can be done in infertility into 3. One of them is tests which have an established correlation with pregnancy. That is, tests that have a direct established correlation with pregnancy. And secondly, tests which are not consistently correlated with pregnancy. And tests which seem not to correlate with pregnancy. So, investigating a couple with infertility, the initial tests that should be done are the tests that have direct correlation, established correlation with pregnancy, and these include seminal fluid analysis, tubal patency test, and then test for ovulation using the mid-luteal phase serum progesterone. The other tests that are not consistently correlated with pregnancy, which can be done if indicated, include the zonal-free hamster egg penetration test, postcoital test, or anti-sperm antibody assay. Then other tests which seem not to correlate with pregnancy or can be done depending on the scenario include endometrial dating or varicocele assessment. The male partner usually should have 2 semen analyses performed during the initial investigation. It's not recommended to assess the semen function with just 1 semen analysis. Usually done at least 2 semen analysis that is done at least 1 month, that's 4 weeks apart. And this, the laboratories that perform this semen analysis should undertake this according to recognized World Health Organization methodology. If any abnormality is found, a repeat second sample of semen analysis can be done 3 months later. Then results of semen analysis done should be compared with the World Health reference values, which have been said that the normal volume should be at least 1.5 mils at least, and the pH should be at least 7.2, the sperm concentration 15 million or more per mil. Then total sperm per ejaculate at least 39 million per ejaculate. Total motility should be at least 40% and 32% at least for progressive motility. Then the morphology should be at least 4% or more of normal forms according to the Tiger-Badge-Treat criteria. The white blood cells should not be 10 raised to power 6 in the semen sample. If the serial semen fluid analysis confirms an abnormality from properly collected semen specimen, then hormonal profile may be indicated in this patient, and they should also have semen culture done, especially in our locality, where there could be infections that could also affect the sperm parameters. Testicular or scrotal scans can also be indicated if there were abnormalities found in the examination of the testis. Then chromosomal studies or genetic studies can also be indicated if there were features or telltale signs of chromosomal abnormality, or if there were grossly abnormal semen parameters. Then there could be testicular biopsy, and then probably to get any sperm to preserve for artificial reproduction technology, and also probably to diagnose any abnormality of the testis. For the woman, there are tests for the test for ovulation. A woman that is menstruating regularly, it strongly suggests normal ovulation. However, the serum progesterone that is done in the mid-luteal phase is what confirms that the woman is actually ovulating. So the serum progesterone that is done in the mid-luteal phase that is within the normal range is what is a confirmatory test for a woman that is ovulating. Can also be serum prolactin can also be indicated, or hormonal profile, especially when the serum progesterone is abnormal. Hormonal assays may not be readily available and may not be affordable depending on where the patient is. There could also be transvaginal ultrasound scan to track the follicles and ensure ovulation when the follicle is no longer seen following a period of tracking. Patient could also have pituitary imaging, probably where there is suspicion of hypothalamo-pituitary failure, or if there is suspicion of hypothalamic pituitary ovarian failure, there could be ultrasound of the ovaries, there could be serum androgens to help to diagnose this. Also, there could be karyotype test to estimate, or to when there is suspicion of ovarian failure. One can do a karyotype, probably it is Turner's syndrome. In such a situation, it will help to explain the reason of the ovarian failure. Then, if there is raised prolactin, pituitary imaging may be done. Probably there is there is a mass that is secreting the elevated prolactin. The tests for tubal infertility include, usually one can do a hysterosalpingogram, which can be used as a screening test for tubal patency in low-risk couples. However, laparoscopy and dye test has been said to be preferable and the gold standard for diagnosis of tubal infertility, though it is said to be complementary with a hysterosalpingogram, but it is regarded as the gold standard for diagnosis of tubal factor infertility. This is just a picture that is showing the pelvis with distorted tubes following a pelvic inflammatory disease. You can see this fiscutis just around the liver, and this is the uterus with the left tube distorted, and this also adhesions which have distorted the position of the tube. Other tests that can be done probably for assessment of the uterus, endometrial cavity, could be saline hysterogram, hysteroscopy, and sometimes hysterosalpingo-contrast ultrasonography can also be done to assess the uterine cavity. And like I mentioned earlier, hysteroscopy can also be done if available. There are newer techniques or recent advances that can also be used to assess tubal factor infertility. This include transcervical falloposcopy, which involves visual examination of the fallopian tube lumen via the vagina using a micro endoscope. Can also do selective salpingography either for the left or the right tubes. Can do fertiloscopy using a combined hydrolaparoscopy and dye through the vagina, and salpingoscopy or micro salpingoscopy and hysteroscopy, which have been around. Then there are recommendations in evaluating a couple with infertility. Some of them were mentioned, but just to mention them again, is that the evaluation of the infertile couple should be performed concurrently between the male and the female to engender a comprehensive decision making. It should not be a process where the male will be investigated at a different time and the female will come back at another time. It may not engender a good decision making. They should be investigated concurrently so that whatever is the issue, it can be noted and a better and more practical line of management can be charted. A practical approach follows a systematic series of evidence-based steps. So the process of investigation should be evidence-based. The era of just requesting investigations just for the sake of requesting has gone. Every test that is requested should have a contribution. It should be seen to have an established correlation to pregnancy. And if possible, all these tests should be done in one menstrual cycle. Then seminal fluid analysis, like I mentioned, assessment of uterotubal status by hysterosalpingography or laparoscopy and dye test, and then mid-luteal phase progesterone for detection of ovulation are basic fertility tests that should be done from the onset. Care must be taken also to avoid burdening the couple with unnecessary tests. So the tests that should be done should be evidence-based. Couples should not be burdened with tests that don't have any established correlation with pregnancy. However, if they are indicated, there should not also be delay in doing those other tests if they are indicated. Sensitivity and tactful handling should be advocated. So the clinician should be sensitive to the needs of the couple and be sensitive to what they are passing through, especially in our locality here, where, as we mentioned earlier, procreation has so much social value. The distress of a couple that has not conceived is quite enormous. So the clinician should understand this and also sympathize with them and also encourage. At all times, consideration should be given to the psychological needs of the couple, because medical assessment and intervention can be long and emotionally draining. These are my references. Thank you for listening.